Política y Política Pública por la Universidad del Sur de California. Actualmente Enrico es profesor asistente de Sociología en San Diego State University, pero ha sido profesor asistente de Economía en la Universidad de Massachusetts en Boston, y también estuvo varios años en la Universidad de Harvard, después de haber estado aquí en San Diego y haber tenido una relación con el Colegio de la Frontera Norte, y además haber sido uno de los presentadores de las primeras sesiones del Seminario. Enrico nos va a presentar el día de hoy un trabajo que denominó, bueno, el título lo tienen en la primera diapositiva de su presentación, y yo me permití traducir distress como padecimientos. Entonces es la relación entre el estatus de los migrantes mexicanos adultos residentes en Estados Unidos y eso que yo llamé padecimientos, me atreví a traducir de esa manera el distress. Entonces le agradecemos a Enrico su presencia aquí, su buena disposición para participar en el seminario y presentarnos los avances de su investigación actual en el campo de la salud de los migrantes.
Gracias. Thank you for inviting me back a second time to present. I did this 9 years ago, maybe? 8 or 9 years ago. And so thank you very much for inviting me back. Professor de la Garza spoke about a crisis in the United States. She said there's a crisis of migration. I would contend that there are many, not just one. And I don't think she meant that there were one. But there is a crisis concerning migration in the United States, and there are many. I would like to speak with you today about one, just about one that I perceive. Ah, yes, okay. Es necesario para mí hablar despacio, ¿no? Voy a tratar. Well, as I said, I'm going to focus on one crisis, and it concerns the almost complete lack of investigation, systematic analysis of how legal status affects health among Mexican and other Latinos in the United States. Now, I want to be clear about this. There's plenty of work by some of the people in this room and by some of my colleagues at San Diego State University and throughout California on legal status and health. What I mean by that statement is not arrogance, is not ignorance. It's a complete lack of systematic quantitative analysis that can characterize the entire Mexican immigrant population in the United States. We have local studies. We have some that are over time. We have some that focus on farm workers. In Fresno, for example, some of the best I've seen. But for the most part, there has not been much attention on looking at how legal status affects the health of Mexican and other Latino immigrants in the United States. Few question, very few people question, the notion that Mexican immigrants, and especially undocumented, come to the United States to earn a better living. However, the short-term and long-term toll on these workers and other U.S. residents is largely unknown. Few really care, that is, I would contend, what the burden of this work and the transition to a different socioeconomic and cultural environment has or is on their physical and mental health, and whether this, like maintaining a large uninsured population, has any harmful or negative spillover effects on other U.S. residents. It's apparent that we in the United States care more about maintaining a low-wage, uninsured workforce exposed to unsafe work conditions than the probable harmful non-economic aspects of unauthorized immigration and the lack of health insurance coverage for immigrants and U.S.-born citizens. So, despite the rising number of unauthorized or undocumented U.S. residents and uninsured residents, and increasing interest in that the relatively impressive health of lower socioeconomic status Latino immigrants compared to U.S.-born residents declines the longer immigrants live in the United States, both in the number of years and across generations. There is almost no representative research on the relationship between legal status and health. It is usually simply assumed that recent Mexican immigrants are healthier than U.S.-born adults on average, and especially more than U.S.-born non-Latino whites. And if Mexicans got to the United States illegally or are illegal, their health must be even more robust, it is assumed, often, or they would not have been able to make the journey and put up with the psychological aspects of living in a hostile environment given their legal status. These are, I want to emphasize, and we must remember, mostly assumptions. Now, before turning to my main topic this morning, which is the sources of psychological distress among Mexican immigrants, and mostly I'm focusing on Mexican adults residing in the United States. I'd like to place this in the larger context of the so-called Latino health paradox. Many of you are familiar with this, but just to restate it, it's the notion that socioeconomic status measured by education, occupation, income, sometimes other variables, is positively related to health. And so if you have a higher income, higher education, you're healthier. If it's lower, you're not. What's paradoxical about it in the Mexican immigrant case and other Latino immigrant case is that for the most part they are lower socioeconomic status and yet very often have better health outcomes. Let me just say something about where this comes from. Although an article by Marquides and Corriel in 1986 is credited with terming this paradox the, quote, Hispanic epidemiological paradox, it actually, the first systemic evidence emanates from an article back in 1974, if you can see this graph, where it looked at infant mortality in the 1950s and 1960s, actually starting from 1964 to 1972, you can see on this graph. And what we see is as we progress in time, the infant mortality of Spanish surveying individuals was higher than that of Anglo individuals, but that it declines over time. You might say then this is evidence that socioeconomic status and health are positively related, like the socioeconomic status health disparities framework contends. However, the point here is that given the socioeconomic status profile of Spanish surname individuals in the United States, their infant mortality ought to be much higher. And it's not. It's equal or above Anglos, for that matter. So this is where the idea comes from, infant mortality. Now, can we believe this relationship between low socioeconomic status for Latino immigrants and better health outcomes, at least as it concerns infant health? Well, there's some subsequent evidence concerning this, and if you can't read this graph, let me tell you what it means. Basically, this looks at maternal education less than 12 years. And in these data, given to us by David Hayes Batista, we see that Latinas have a much higher proportion who have less than 12 years of education, over half of them, compared to much lower percentages in the top graph of women of other ethno-racial groups. Down below, we see that Latinas are also not least likely, but less likely to receive first trimester prenatal care. And so these are just some statistics to suggest that indeed Latinas, most of whom are Mexican in California and other southwestern states, have a lower socioeconomic status. Does that translate then into better health? And what we see here is that indeed it looks like there is a relationship that challenges the notion that higher socioeconomic status automatically leads to better health outcomes. Here you have relatively low socioeconomic status women, and here you can see on the right-hand side The top graph shows that they have lower proportions of low birth weight babies, and they have lower rates of infant mortality in the United States. So it appears that something strange is going on here, right? Low socioeconomic status, better infant mortality, better infant health outcomes. That's where it comes from. But is this convincing evidence? I would submit to you that it's not. I would submit to you that unless you control for a host of other possible determinants of health, you cannot conclude from these very crude and basic descriptive statistics that one is causing the other, that socioeconomic status is causing it or is not causing it. You have to control for a lot of other variables. And so this isn't convincing to me. It's provocative, but it's not convincing. And so, for example, while this controls for ethno-racial group, you don't see any controls here necessarily for age, nativity, or how long people have lived in the United States. All right? Now, he has gone on and done much more sophisticated work that does that and still shows evidence of a Latino health paradox. But this is some of the evidence that's often provided that is provocative but not necessarily convincing. And so there's some other evidence here, very early evidence in the 1970s, that suggests that it's very important for us to control for age. In other words, here we see that when we control for age and gender, we get a different story about the health of immigrants in the United States. When we look at those who are aged 35 to 64, it appears that immigrants or foreign-born persons are much less likely to die in a given year, whether you're looking at males or females. But after age 64, controlling for age that is, it looks like immigrants or foreign-born persons are more likely to die in a given year. Now, these are very old data, but it makes the point that if we fail to control for age, we fail to control for gender, and many other factors that I'll suggest to you in a moment, then we are not really measuring whether or not there is a paradox. We have to look at these other variables and not just look at income or education and health. We have to look at a host of other variables where we cannot conclude, number one, that there really is a relationship or that it's causal. Here you'll see that women fare worse. Women are clearly worse off than men, or were worse off than men in the United States. And the transition after age 64 is worse for women than it is for men. So it's important to control for age and gender, it appears. Here's some more evidence from Professor Hayes Batista. And here you can see that if we look at all-cause mortality, that's not just infant mortality. If you look at death for any reason whatsoever, you'll see here that it looks like Latinos, both males and females, have lower mortality. This is pretty convincing evidence on the surface. Again, that in this case, that immigrants are less likely to die in a given year. But here, we're controlling for gender. And I believe it is age adjusted. So it's age and gender once again. And by this, it appears that there is a paradox. If we assume that these age-adjusted, gender-adjusted statistics are people who have less income, less education than the other groups, and indeed they do, if you look at the rest of the data. But there's no consideration here of immigration status, let alone legal status. These are just ethno-racial groups. There's no consideration here of time residing in the United States. One last group of statistics, or actually I'll give you one more after this, of evidence that's been offered to look at the Latino health paradox comes from some work from Yasso, Massey, Rosenzweig, and I'm sorry I forget the fourth author in this work. But this is some pretty sophisticated work looking at national health interview survey data in the United States, but for 1 year. And what we see here is that the foreign-born, represented by the blue bars, have lower levels of chronic diseases. I've only picked 3 here. But in general have lower levels of chronic disease, hypertension, heart disease, and asthma, almost throughout the entire life course. But that difference becomes smaller as they get older, consistent with the switchover that we saw from Kitagawa and Hauser when you control for age, that immigrants are more likely to die in older age than they are in younger ages. Here we see when we turn away from mortality to morbidity, diseases and other illnesses, that the story seems to be the same. But the gap seems to narrow with age. Yet more evidence that we must control for age, and that the advantage fades with age. Now, what about biological risk profiles? You say, what the hell is that? Well, a biological risk profile is an effort to look inside the body rather than looking at what people tell us or just death records, and try to understand, are people who are alive, without knowing or necessarily even believing what they tell us about their health, can we know something about people's health and well-being by looking at biological markers, for example, in terms of their blood pressure, in terms of with the blood pressure, which is the blue bar. The red bar there is the total biological risk as measured by Eileen Crimmins and her colleagues in a recent article in the American Journal of Public Health. And what they do, using what's called the NHANES data in the United States, they look at biological risk factors for high blood pressure, or very low blood pressure for that matter, but high blood pressure usually. They look at metabolic risk in terms of cholesterol, in terms of glycated hemoglobin, or HbA1c it's called. They look at inflammation risk, fibrinogen, which is a chemical which is produced when we're threatened and that is used to create, to coagulate your blood. In any event, there are markers for biological risk that we can get at that some researchers now are using to try to understand how our body responds to insults and threats that we receive, physiologically, not just psychologically or in terms of symptoms of diseases then. So if you look here, it looks pretty clear also, if you look all the way over to the left, that Mexican foreign-born persons living in the United States, these are adults 40 years and older, by the way, that they have lower levels of blood pressure risk, lower levels of metabolic risk, and lower levels of inflammation risk compared to other, and lower levels overall when you look at all those 10 markers that they used. However, white is almost in the middle, non-Latino white. You see in the middle there? That's what we're comparing to here. When we compare that Mexican foreign-born group that I just drew a circle around with those whites that are somewhat in the middle, you'll notice that Hispanic and Mexican U.S.-born are worse off, and blacks are the worst in general. You'll see that only in 4 cases is the difference from whites statistically significant when we control for age, gender, behavioral factors such as exercise, smoking, diet, and when we control for access to health insurance and medical care. So we see that Mexican foreign-born have no little red flashes above the bars, meaning that although descriptively they have lower biological risk, they are not better off compared to non-Latino whites. So this is not evidence of a Hispanic or Latino, or at least a Mexican health paradox when we look at biological risk factors. So what do we ascertain from these data? And by the way, this is all by way of introduction, and I'm sure I need to speed it up a little bit. But what we can ascertain is that there's uncertainty regarding whether there is a Latino health paradox in the United States, despite many, many people just assuming there is. Infant health data support the paradox. Recent all-cause mortality data support it. Recent adult self-reported morbidity data provide mixed evidence. I didn't have time to show you this evidence here, but I could if we had time. And recent adult biomarker data challenge it. So there's mixed evidence for this Latino health paradox, and I think it's silly for us to think that just because Mexican or other Latinos have better health on some outcomes, that it's the case for every single one. Are Mexicans healthier than those born in the United States on everything? Why do we assume that? Well, I've already mentioned that we need to look at duration of residence. We need to look at generational mobility. When I say that, I mean not just geographic mobility, but socioeconomic status mobility. And I am going to be focusing today on legal status. I have not found one study in any journal, and I would like someone to show it to me if it exists, that looks nationally at Mexican health and looks at legal status. There's a very simple reason. Nobody has the data. And that's why in 2003, in the last INS report, not Department of Homeland Security, but the last INS report that was produced by Robert Warren, that tried to adjust for the undercount rate in the United States of unauthorized or undocumented immigrants, used my estimates from Los Angeles County from the COLEF UCLA Mexican Immigrant Legal Status Survey to adjust for all immigrants from any country across the United States. Ridiculous, right? But what did these demographers say to me at the Census Bureau and at the INS? We don't care, Enrico. This is what you found and nobody else has data on this, so we're going to use it. Okay, fine. I'll tell you toward the end of my talk, we're now doing this with Brazilian immigrants in Boston. We're doing this with Dominican immigrants in Boston. There's other studies that have done it in Chicago with Mexicans that we'll talk about here at COLEF and some other places that are now replicating this methodology that we used. And for the next census, 2010, we're going to have better data and more of it for other Latin American groups. Notice I didn't say Latinos, because Brazilians, at least in Boston, I'm learning, don't consider themselves Latino. They consider themselves Latin American immigrants. But nonetheless, we're going to have better data of undercount, health, etc. for Latin American immigrants as we approach 2010. What are our questions? And I failed to acknowledge two people who have been very helpful to me in this study, and I want to do it now before I tell you what our questions are. Louisa Holmes is a PhD student at the University of Massachusetts, Boston, and she's been very helpful in this research. And Philip Granberry, who just received his PhD from University of Massachusetts, also helped with me very much in getting these data ready. In any event, I'll say more about the Mexican immigrant data in a moment and thank COLEF and other people who made that possible. The first question is, what is the relative health of Mexican immigrants residing in the United States? Is there a Mexican health paradox? I've already hinted that I'm very skeptical. I'm very skeptical to call it a paradox when you only find it for a few health outcomes. Call it an infant health paradox. But why call it a Latino health paradox if it's not for the majority of health outcomes? Secondly, are any observed adverse health outcomes due to legal status stress or to behaviors and barriers related to unauthorized legal status? I have a lot of people to be thankful for here who've done a lot of important work on this topic before me. Anthropologists, political scientists even, on health, epidemiologists, public health scholars, sociologists, not many economists. But for the most part, I have a lot of debt to people who have done local area studies on certain populations who have suggested that this might not be the case. So what are the data we're using? Here's where I want to thank COLEF. I want to stop and thank COLEF because although I've been formally educated at the University of Southern California, UCLA, UCSD, Harvard University, now I have to tell you, and Jesus Montenegro is not in the room, and nor are some of the other people from COLEF who trained me on how to collect credible data for Mexican immigrants in the United States. Without our collaboration, that is now since 1994, without our collaboration working together to have Mexican immigrants interviewing Mexicans interviewing Mexican immigrants in the United States, without all the women immigrants who did those questionnaires, we would not have been able to collect credible legal status data. I'm finding that now to be true with Brazilians and Dominicans in Boston as well. So the 2001 COLEF UCLA Los Angeles County Mexican Immigrant Legal Status Survey, or LACMILS, was funded by the University of California Office of the President and then subsequently by the CPAC, the Center on Program for Access to Care. Basically, the University of California has funded both the collection of the data and my initial analysis of it, and so I'm thankful to them. I'm also thankful to the Robert Wood Johnson Foundation, who also has funded me since then, who's given me time to carry on this work, moving beyond just simply how unauthorized or undocumented Mexicans affect economic outcomes of other residents in the United States, their wages, their employment, their use of welfare, their use of illicit drugs, and their access to insurance and medical care, but now turning to an issue that I think is really important, and that is health. That is important not just for Mexican immigrants, but for all residents of the United States, for economic and non-economic reasons. So the 2001 data is a random household survey of 459 households, over 800 people, I invite any of you who are interested in investigating unauthorized legal status and how it affects Mexicans in the United States to approach me to talk about possibly using it. These data have been used to do some of the things that I've already mentioned to you. And we randomly selected these households from neighborhoods that were highly concentrated with Mexican immigrants. And we've published a number of articles on this, so I won't take a lot of time to talk about the data. But it was truly a joint effort between, at that time, UCLA and COLEF. The first one in 1994, and we owe a great debt to David Hare, my dissertation advisor, a demographer and sociologist who died this past summer in San Diego, who created both the dominant methodologies in the United States, both of them. One in a 1979 demography article, and the second one with a 1992 article, a book, and then the work that we did in the 90s on the second methodology, which this is an example of. The first methodology is for aggregate estimates in the United States, which Frank Bean, Jeff Passell, the INS, the Census Bureau, a lot of people use today to get our estimate of 12 million undocumented immigrants in the United States today. He introduced it. The second methodology is the survey-based methodology that many people are replicating now. It allows us to get individual level data about Mexican immigrants, which the other methodology doesn't allow. So they both have advantages and disadvantages. Anyway, what I'm going to do is use the 1998 to 2005 National Health Interview Survey data to estimate health outcomes for Mexican immigrants compared to others in the United States. But secondly, I'm going to apply legal status predictors from our Mexican data in LA County to the Mexican foreign-born population in the United States. Obviously, there's problems with that, but I'll tell you up front, it's so hard for me to sit down when I'm speaking or to sit still, but I'll stay in front of this camera. The question here is, can we really believe legal status predictors coming from Los Angeles apply to Mexicans across the entire United States? Of course not. But that's why we're going to use the Chicago data. We're going to replicate these surveys again in multiple locations in the United States to see if it's valid. But for now, again, like the INS said in 2003, it's the best we got, so we're going to do it. And we're going to see how unauthorized Mexican immigrants compare to others in terms of their health outcomes. So you might recognize somebody in this picture. He's not here again right now, but Chuy, or Jesus Montenegro. This is at UCLA, at the Lewis Center for Regional Policy Studies, where we designed and implemented this study, COLEF and researchers from UCLA. Many of these people are in graduate programs at UCLA, some are at UC Riverside. But the bottom line is this is our supervisory team and the team that really trained all of our interviewers and made it happen. The methodology is to generate demographic predictors of legal status. So those predictors are age, sex, how long you've lived in the United States, and education. And with those four variables, if you can give me those four variables and I take our predictors, I can predict with between 87 and 95% probability, accuracy, what your legal status is. Perfect? No. Better than what many others have done and are doing? We believe so. For example, some people just take those Mexicans who have arrived in the last 5 years and count them all as illegal. That's ridiculous, in my opinion. Not all Mexicans who arrived in the last 5 years are illegal. So this methodology has been tried over and over again, and it appears to come up with consistently credible estimates of the number and characteristics of unauthorized, at least in California. So we apply these predictors then to the NHIS data, and then we compare non-elderly foreign-born Mexicans on 15 age-standardized morbidity, disability, and functional limitation health outcomes with other adults living in the United States. These are the outcomes that are available to us in these data. And then we test whether legal status itself, unauthorized or undocumented legal status, helps explain why Mexican immigrants have poorer health outcomes on 8, which I'll show you. By the way, there's a mistake in the abstract. I gave false information. There aren't 7 worse health outcomes for Mexican out of the 15. There are 8. So it makes a difference because, my fault, my mistake, but you'll see I forgot the liver conditions, and that makes 8 out of the 15 worse. So we want to see if legal status per se has an adverse effect, unauthorized legal status has an adverse effect on any health outcomes in the United States. Now, some experts say, and these are some heavies, some important people in this field of research. Frank Bean and one of his students have quoted in a very important publication, the binational study, that the unauthorized migrant population is difficult to measure directly. Data obtained from survey items about legal status may be highly questionable, if not worthless. Worthless. The last 15 years of my life spent studying this is worthless. But in any event, he doesn't mean that. Actually, they respect our work, but they are right. It is difficult and very costly and impossible without working with Mexicans, in my opinion. Somebody else who's fairly well known, Doug Massey, we cannot measure the net immigration of illegal immigrants. Really? Okay. Barry Chiswick. Illegal immigrants have an incentive to avoid revealing their status to an interviewer or in a questionnaire. Really? Of course they do. That's the whole point of research, to try to measure things that are difficult to measure. And so with Mexican women working with a community-based organization, working with a reputable university from Mexico, we think, and it's not important just what we think, now many others, as I'll show you in a minute, think that this methodology is the most credible methodology in the United States for doing so. Let me give you some examples. Jim Smith, an economist at the Rand Corporation in Santa Monica, has said, and I quote, "This is a well-accepted method of classifying legal status and survey of immigrants." Wow, I didn't know that until I read Jim Smith had written that with some of his colleagues at Rand. But it is. It was pioneered by David Here, as I've mentioned, and developed further in the 1990s. It was used by Colef and some of us at USC and UCLA in the 1990s and then 2001 again. The California Health Interview Survey, one of the largest health surveys in the United States, uses it. The Los Angeles Family and Neighborhood Survey, headed by Ann Pebley and centered at UCLA. Both of these are centered at UCLA. Both use the kind of legal status methodology that I'm talking about after we did it. In 2005, Colef did it. I just learned 3 or 4 weeks ago. Now that I'm back in California and we can start meeting more and working together, hopefully, I've learned that Colef did it in 2005 with a Chicago study. And we just did it with a Harvard School of Public Health, UMass Boston collaboration funded by the National Institutes for Health. Just entering the data now with Brazilians and Dominicans. So there's a lot of people doing it, and it appears to be that people believe it works. So, you may have seen this cartoon before. What do unauthorized Mexicans look like? I doubt they look like the people on this boat. But in any event, it's important to get good data, credible data, if we're going to understand what unauthorized immigrants look like. Okay? This is what they think they look like in New England, where I was for 6 years. Anyway, because they don't do much research like this. In fact, our surveys are the first in the Boston area to ever collect random household data that also has legal status data in it, and biological health markers. Okay, so how do we determine legal status? We ask 6 questions. Are you a U.S. citizen, yes or no? If you say yes, we believe you. If you say no, are you a legal permanent resident? Yes or no? If you say yes, we don't necessarily believe you, because in our focus group research, we have found that people will lie on that question. And so we then ask subsequent questions about how you got your green card. If you said no to each of those questions, we then ask, are you a non-immigrant visa holder? And if you say no to that, you can only be one other thing. Assuming you don't have temporary protected status. You must be an undocumented immigrant. So really it's 3 questions. Are you a citizen, yes or no? Are you a legal permanent resident, yes or no? And are you a temporary visitor? No, no, no. The result is you have to be undocumented. We can then take those responses, do some sensitivity testing, and try to build a model that predicts that status. That's the methodology. Not complicated, difficult to collect the data, but growing in importance. Here's the kind of thing that we did in California years ago, using both our 94 and our 2001 predictors. We estimated the number of Mexican and other Latinos who are unauthorized in the United States, and we saw a 61 to 75% rise in California, despite Proposition 187 and 94, despite 1996, legislation which was not very positive toward legal or unauthorized immigrants, despite the September 11th attacks in New York City. Constantly rising unauthorized immigrants. So to get to our results now, for what we're doing today. Not just the estimates of the numbers, but what are some characteristics, behaviors, and access to care for Mexican immigrants versus others. This is going to be difficult to see, and I've cut out several of the variables that we have investigated that are important for explaining health outcomes, because I don't have room to show anything, or room to show everything, or time to show everything that we've looked at. But what I want to show you here are some of them. First of all, Mexican immigrants are more likely to be male. You'll see on the far left group of colored bars, over 50%, whereas the percentages in others is lower. This is important it's important to realize that these are statistically significant differences for the most part, because I have over 170,000 observations I'm looking at. This is a very large sample of data. So even small differences, for the most part, are different statistically. Unauthorized residents, Mexicans are likely to have a higher proportion who are unauthorized, hence the reason why legal status might matter more for Mexicans. They are less likely to currently smoke, less likely to drink heavily, and less likely to exercise, but the differences here are very hard to see. The point is that Mexicans have better health behaviors than U.S.-born residents and others of different ethno-racial groups. They have more positive health-related behaviors, I would say, in some outcomes, such as marriage. Marriage tends to be a protective effect on many health outcomes. They are more likely to be married. They are less likely to have graduated from high school, significantly, substantially less likely. They are more likely not to have health insurance. They are less likely to have a usual place to get medical care. So these are just some of the possible explanations of why you might think, in a comprehensive model of health that should include biological factors but can't in these data, but looks at behavioral factors and looks at environmental factors to some extent. We're controlling for where they live in the country. I'm not showing that here. And looks at access to health insurance and medical care. There are 7 health outcomes for which Mexicans living in the United States were not worse off compared to U.S.-born non-Latino whites. When we look at 15 health outcomes, we find that they are equally well off or better off in these 7 health outcomes. So they're less likely to have hypertension nationally, not controlling for legal status right now, just all Mexican immigrants together. Less likely to have hypertension, cardiovascular disease, all types of cancers, although on some cancers they're more likely, on all types they're less likely. Less likely to have lower respiratory diseases, less likely to have hepatitis, joint and other chronic pains, and less likely to spend time in bed because of illnesses and diseases. These are all age-adjusted. Okay? Now, as I said, on 8 of them, Mexican immigrants are worse off. And now I'm going to show you 8 charts, 8 figures, to show you where they compare to all the other ethno-racial nativity groups that we're looking at. These are age-adjusted outcomes again. I want you to realize that. That's important because Mexicans are younger. And if we don't adjust, we're getting an incorrect picture of the relative health of Mexicans. Here we see that Mexican immigrants are less likely to report very good or excellent health. This might be due to cultural reasons, but just looking at the raw data, age-adjusted, descriptively, it looks like they're worse off when it comes to their own perception of their overall health. They are more likely, and I'm saying this more likely compared to U.S.-born whites, which you can see are third from the left on this graph. All these graphs I'm saying more likely or less likely. They have worse health outcomes on these 8 compared to U.S.-born non-Latino whites. Is that clear? All right. So here we see that they are more likely to be seriously psychologically distressed. This is a problem because most research contends that Mexican immigrants have better mental health, as measured by psychiatric disorders and other measures, you might argue even better measures of mental health. But according to these data, they're worse off. They're more likely to be obese. They are more likely to have diabetes. Mostly, this is type 2 diabetes. It used to be called adult onset diabetes, but no longer. In this case it is, but children are also likely to get type 2 diabetes today as well. They are more likely, most likely in fact, to have kidney problems compared to every other group. Almost 3% of them, adults, have kidney problems. More likely to have liver condition. This is the one I left out by accident when I sent my abstract. They are more likely to have limitations for activities of daily living, taking a bath or a shower, getting dressed. More likely, not less likely, more likely than other residents in the United States, at least non-Latino U.S.-born whites. And lastly, they are more likely to have tuberculosis, or to have had tuberculosis. 8 outcomes worse, 7 outcomes less. Did I pick these outcomes to come up with findings that would suggest that the Latino health paradox or the Mexican health paradox should be seriously questioned? My answer, and my honest answer to you, is no. I didn't look for those outcomes that would give me the majority bad health outcomes. I looked at 15 that represent a lot of diverse kinds of health outcomes that are the most important health outcomes for mortality in the United States, and on 8 of them, the U.S. are worse off. So let me summarize our results. The red are the bad outcomes, the 8. The green are the good outcomes. Here's all the differences between Mexican immigrants or migrants and U.S.-born non-Latino whites. We see that they were 4% more likely to be diabetic, 3% more likely to be obese, and it goes down the line like that. 2.5%, maybe 2%, maybe 1%, a little less than 1%, or 0.5%, to be more likely to have a kidney problem, liver condition, seriously psychological distress, and all the other outcomes. They were more than 15% less likely to say they have very good or excellent health than non-Latino U.S.-born whites residing in the United States. So this suggests to me that the Latino health paradox perhaps should be questioned. I'm not the only one. I showed you evidence of some people who are doing more biological data, looking at biological data that also question it recently. Now, let me just point out here, one of the main reasons why I think we are fixated on a Latino or a Mexican health paradox is because it is true. The things that kill most people in the United States, Mexicans are worse on. Right? Oh, I'm sorry, better on. Better, not worse. They are much less likely to have cardiovascular disease or to have had all types of cancers, like more than 5% less likely. So if we're fixated on the things that kill us, then yes, maybe there is a Mexican health paradox. But if we're looking at morbidities, health defined by everything than the worst health outcome, death, then it appears that the paradox is questionable. Now, what about this idea of legal status? Is there a penalty for legal status, unauthorized legal status among Mexicans in the United States? On those 8 health outcomes where Mexican immigrants are worse off compared to non-Latino U.S.-born whites, and these are the 8s, grouped by legal status. So if we take the top one, for example, obesity, we see that authorized or legal Mexican migrants, which includes legal permanent residents and naturalized citizens, they are slightly more likely to be obese than unauthorized Mexicans. Just a little bit more. They are much more likely to be diabetic. They are more likely to have a liver condition, more likely to have tuberculosis, more likely to have a kidney problem, and more likely to have reported very good or excellent health. So on 6 out of these 8 health outcomes on which Mexican immigrants are worse, legal immigrants are better off compared to non-Latino U.S.-born whites. Does that make sense? They are worse off on 2, which in my mind makes a lot of sense and has some support in the academic literature. Unauthorized Mexican immigrants, it appears, this is the first evidence in the United States to suggest this, it appears, are worse off psychologically than their legal compatriots. And there are many hypotheses why you might think that's true. The only 2 outcomes they're worse on is self-reported health, which has a strong psychological or cultural component, you could argue, that doesn't match up perfectly with actual physical health, and secondly, on serious psychological distress. Those two groups. That's where the green bars are lower than the red bars. The red bars are worse off. So there seems to be a penalty, a psychological penalty, for Mexican immigrants residing in the United States who don't have legal status. I know this comes as no surprise to any of you, perhaps any of you in the room, but when the majority of the mental health literature suggests that Mexican immigrants are healthier than non-Latino whites, and when it suggests that doesn't matter compared to legal status, this is really different evidence. The best work that I have found that almost gets at how legal status affects health or psychological outcome is done by actually two of my colleagues and William Vega, Brian Finch and Bodem, is that how you pronounce it? Collodi. They have done an article with Vega in the Journal of Health and Social Behavior where they look at perceived discrimination and depression among Mexican origin adults in California. And interestingly enough, if you look here, they're measuring the level of acculturated stress that's related or linked to legal status stress. And they're looking at the predicted Center on Epidemiological Studies depression score. This is more of a psychiatric measure, not the psychological measure that I'm using. But it suggests that the higher the level of perceived legal status stress due to legal status, the worse is their mental health psychiatrically, actually, by this measure. The striking thing about this graph is that while it's higher for Mexican migrants, as the little circles show, it's highest for people who were born in the United States of Mexican origin. In other words, the whole legal status situation, or the distress that it might be causing, actually appears to be greater for non-immigrants, Mexicans. So it has an adverse effect on U.S.-born people of Mexican origin. This is surprising to me, and they come up with some reasons in their article which they suggest are believable. I don't know that I believe these results, quite honestly. I think it might have something to do with the fact that we're relying on information that's reported by the respondents, where what we're doing is not relying on what they told us. We're not saying they're distressed because they said they were distressed. We have a measure that I'll get to in one moment that comes up with an index of psychological distress based on 6 questions, and then we're relying on a predicted or a classification of legal status based on what they told us, never asking them directly, are you distressed or stressed, or are you legal or not? All indirect questions, but directly asked of the migrant respondents. Here are some hypotheses from the only article in the academic literature I could find on mental health and unauthorized Mexican immigrants that summarizes the literature. And this summarizes the Finch article that I told you about and many others. But these are reasons: socioeconomic failure in the home country, dangerous border crossing, limited resources, restricted socioeconomic and geographic mobility, isolation, marginalization, blame, being exploited, fear of deportation, stress-related health problems. So the actual somatic or symptoms of stress might be a reason for, in a cumulative way, increasing stress or psychological problems, right? We know that poor health also influences mental health. So it's not just poor physical health influences mental health, but it's both ways. In any event, these are some hypotheses, most of which have not been systematically studied in the literature. There's also some evidence from the sociological literature. Here's an article, a fairly recent article, that really builds on developments in social epidemiology, which I have been trained in, and neuroendocrinology, which studies the hormones that are released when somebody's threatened, either socially or physically, and how that can affect health outcomes. And what we see is that from sociology, we have plenty of evidence of how stratification, or inequality, on the one hand, or residential segregation of people, can concentrate poverty and violence and behaviors and noxious environments that can adversely affect health. There's a whole movement in the United States of environmental justice that speaks to this. But the idea is that we concentrate inequality and segregation in areas that concentrates predictors of poor health outcomes. This then can increase what's called allostatic load, which is really a fancy word for accumulated stress over a long period of time. That can be related to chronic diseases and illnesses, such as the three that that are listed up there in Massey's biosocial model: coronary heart disease, inflammatory disorders, and cognitive impairment. So the one that we're interested in is actually highlighted in Massey's work here. My question is, where does legal status fit in this picture? Or does it fit? Or do we need a different model? I think this is the provocative model, a helpful one, and one in which we can fit legal status, actually. Because there is stratification or inequality and segregation by legal status in the United States, other researchers have shown us. And if that's the case, then we can suspect that these might lead to distress or mental health problems among undocumented immigrants, highlighting some of the factors that are listed in Margaret Sullivan's review of the literature, fairly recent review of the literature, but in a more systematic way. I think this is a more theoretically grounded and comprehensive review of how these factors might influence mental health and other outcomes. Now, we have shown some previous work. This comes from an article that Manuel Pastor, who is now at the University of Southern California, and I published years ago, that looks at tensions between non-Latino blacks in the United States and undocumented Mexicans. And we have found that over the 10 years going from 1990 to 2000 anyway, if you look at the areas that have more than 10% undocumented Mexican male workers, it goes from no areas that have more than 10% to at least 2 that have very high concentrations of undocumented Mexican males. Now, if concentration, like the Massey model tells us, is one factor that can lead to more stress, physiological responses over a long period of time that lead to poor health outcomes and symptoms, then this means that we perhaps should be focusing on legal status as a potential predictor of certain health outcomes. Now, I want to give you just a quick refresher before I conclude. And I got a nod saying that I should do so. First of all, stress is often confused in the literature and what it is. Those things that cause stress in our life are not stress. So if you have a stressful work environment or a terrible marriage, I'm sorry, but that is not stress. Those are things that produce stress. Stress is more what our emotional response is to it, our affective response, or our physiological response, or how we behave. Those are the 3 types of responses that most stress researchers see as stress. And the one I'm focusing on here as I conclude is distress, psychological distress, the top one, emotional distress. And then lastly are the health outcomes, cardiovascular disease, cancer, a number of other things that are health outcomes. Even, I would say, the more physiological measures of mental health that we've alluded to here today. Okay? So I'm focusing on this psychological distress, and it's what is called, for those of you who know this work, the Kessler scale. It's 6 questions. During the past 30 days, how often did you feel sad, nervous, restless, hopeless? Everything was an effort or worthless. And you can say none of the time to all of the time and rank these. If it's above 13, you're seriously psychologically distressed. This is well approved of in the literature. And what do we find? First of all, I already showed you. Unauthorized Mexicans are more likely than legal Mexicans and non-Latino U.S.-born whites to be seriously psychologically distressed. That's what that figure was that I showed you earlier. Here's what we find. The bars that have no color in it are factors we had in our model that were not statistically significant. All the green bars are significant. And what I want to point out to you, if I could, with my pointer on the screen, is the unauthorized Mexican migrant bar. 1, 2, 3, 4, 5, 6. 6 over from the left. You have almost a 1% higher chance to have been seriously psychologically distressed as an unauthorized Mexican immigrant. Now you say, big deal, 1% more. Please. First of all, there's only 3% who are seriously psychological distressed. That's like a huge increase. Almost a third greater, right? And secondly, that's controlling for socioeconomic status variables. That's controlling for nativity, race, employment, marital status, a host of other factors, access to care, age, and still we have an effect. This is the only health outcome in the United States for which unauthorized Mexicans seem to be worse off, in a systematic way, controlling for a host of other factors, not just controlling for age and gender. And so to conclude, I will just say that if you look at that effect of unauthorized status up there, that's the change as we add more and more controls in our model. I don't have time to show you all these models, but it's more than 1% effect if we have no controls. That is actually just age and gender. But if we add health behaviors and being married, on which unauthorized Mexicans are better than U.S.-born residents, and bring them down to the level of other U.S. residents, we see the undocumented effect is greater on distress. So they're protective. And if we take them away, Mexicans are worse off. We take away their health behavior and their marital protective effect, they're worse off in distress. If we add a improved socioeconomic status and improved access to health insurance and medical care, we see the distress effect is lower now than 1%. Okay? That's what that means. Second to the last slide, really. In past work that we've done that you have been kind enough to publish in your journal, which I want to congratulate you on, by the way. Migraciones Internacionales has become, I think, a journal that is increasingly getting a lot of attention in migration studies research, and I seriously thank you for publishing the first study I ever, second study actually, I ever published on a health-related topic. But this comes from that article, and here we show that if access to insurance and care matters that much for the distress of unauthorized and Mexican immigrants, then we got a problem, because between 55 and 70% of unauthorized Mexicans don't have it in the United States. And even legal immigrants have 40 to 50% who don't have it. That's a serious problem, not just for the immigrants, but for the rest of the United States population, because if you let these things go over a long period of time, not only do they lead in worse health outcomes, chronic diseases, if you believe the biosocial model of Massey, but a more costly healthcare system for all other United States residents. And to conclude, I just want to, and not with my work, well, but with two of my colleagues, Mark Pauly at University of Pennsylvania and Jose Pagan, who's at Panamanican. Is that University of Texas School, Panamanican? I think. So Jose Pagan and Mark Pauly have found, and this is the last slide, and I'll close with this, that in those places with high levels of uninsurance, that's the blue bars there on the left, compared to areas with low levels of uninsurance, you will see that other people who have insurance were less likely to have a place to go for needed care when there's more uninsured people in their midst. They are less likely, insured people are less likely to have visited a doctor in the previous year when there's more uninsured living in their midst. They are less likely to have visited a doctor in the previous year for a routine exam, meaning a preventive exam. They are more likely in a high uninsurance area to have had a problem getting a referral during the previous year, and they are less likely to have been satisfied with their health care provider. What is my point here? This is not just a legal status issue. To the extent that you have high levels of undocumented immigrants in an area who are uninsured and other people who are uninsured, you have problems for other residents in that area. Therefore, we better take these problems serious, and we better stop thinking that all Mexican immigrants are healthier than U.S. residents, or in the long run, we're going to have a problem. Health is not just mortality and infants. It's also older people, and it's also illnesses and diseases that we're dealing with, some of which we can't even see, that are inside the body, and take more of a biological look. Thank you.
Gracias, Enrico. Entonces, ahora vamos a pasar a la sesión de preguntas y comentarios, y parece que ya por la hora solo está conectado Casa Colegio, entonces voy a preguntar si hay preguntas o comentarios allá en Casa Colegio en Coyoacán. No te escuchamos, Pedro, hay un problema con el micrófono. No.
¿Ahora?
Ahora sí.
Okay. I'm Pedro Alvarez from Caritas, and I have a little big question. But I think that the genomic map, the ALOP map, is more determinant to the stress or the other syndromes in the Mexicans, and I don't understand very well what's the force to compare the different ethnic groups when the determinant is the genetic profile is more strong than the legal status. What do you think about?
I think this is a fantastic question, and I can tell you first of all that we have very, very little data in the United States that allow, in fact, we have no data of which I'm aware that looks at legal status and has biological markers or biological data. I'm aware of none. So, do I agree that they are more similar in biological factors? Of course. We're also closer to chimps, monkeys. But it doesn't mean we shouldn't compare on socially determined factors and how that influences people's health. It's not just unauthorized Mexicans who are being discriminated against in the United States, but it's also legal Mexican immigrants. It's also U.S.-born citizens of Mexican origin in the United States. And it is time, in my opinion, that we stop ignoring legal status as a variable that is important for measuring the health of immigrants. If we think that the socioeconomic status health disparities model, which is the dominant model in the United States of health, if we think that that is true, and we think there is a Latino health paradox, I think it's long past time, and there's many who agree with me, that it's time to look at perhaps the variable that might be the most important one in determining integration or acculturation in the United States, legal status. So, one last thing, and again, thank you for your question. One last thing is that in our project in Boston, we have collected what we think is the first data on stress, long-term stress, chronic stress, among a Latin American immigrant population, Brazilians and Dominicans. We haven't done it with Mexicans yet, but Colef and I have begun talking about how we need to expand our surveys to get biological data of immigrants. Now, there are some studies that are underway right now, funded by the national government, the Hispanic Health and Nutrition Examination Survey, that are collecting, in 4 places in the United States, that are collecting biological data. And they have some data that have collected that nationally, which the Crimmins article that I showed used. There is some biological data, but none of these have legal status in them. That's the point. And so I think we should combine the two. I'm not going to agree that it should be one or the other. Health is more than biology. Much more than biology.
Thank you very much.
Thank you.
¿No hay más preguntas en Casa Colef?
Una pregunta.
Hello, my name is Georgina Olson from Excelsior newspaper. Just want to ask if, just to make sure, you presented a diagram to be sure if socioeconomic inequality and residential segregation are 2 of the main reasons provoking a greater deal of mental diseases. And I was also curious to know, you were saying that there were certain diseases such as chronic diseases where Mexicans were better off, but there are other diseases as diabetes and where Mexicans are worse off. Just if you have any hypothesis or interpretation or why are Mexicans better off in some diseases and worse off in some of the others? Thank you.
Thank you for your question. I think that the diseases and the illnesses that Mexican immigrants are better off, many of them are long-term chronic diseases. It's not that, for example, obesity and diabetes are not long-term illnesses and diseases, but cardiovascular disease, cancer, etc., are longer term, in the sense that the longer you live, the more likely you are to have them. And Mexican immigrants they do have a younger age profile than other people in the United States. So, take another one they're better off on. The number of days they spend in bed. Do I have a hypothesis about that? I do. It goes along with the typical stereotype of Mexican immigrants in the United States. They're coming to contribute and to work, and they're less likely to stay at home when they have a cold. Perhaps. At least this is what the data are showing. So I think it's a hard question that you ask. I don't see a general pattern that explains the 7 health outcomes that they are worse off on, and the 8 that they are worse off on, and the 7 that they are better off on. But my initial guess would be that it's a mix of behavioral, cultural, and biological factors that are explaining that, but also the demographic profile of these immigrants. So I'm not giving you an answer. What I'm saying is that health is multifactorial. It's a result of biology, it's a result of behavior, it's a result of environment, and the interaction of all 3 of these things. And I don't think we can really understand why Mexicans are better off on 7 and worse off on an 8 unless we have good data that measures what the previous gentleman asked, biology, in addition to these other 2 factors. Oh, and I forgot one. Health, access to insurance and care, which does not fit neatly into those first 3 categories. Biology, behavior, environment, and care. We need all 4 of these to understand the differences between these health outcomes, would be my response. And I'm just getting started with this work. I don't know which factors best explain which of these 15 different outcomes. I've only done it for psychological distress right now, and it appears like it's a mix of family, legal status, and other factors.
Gracias. ¿Ya no hay preguntas en Casa Colegio?
No, Manuel Ángel, ya no hay.
Gracias. Gracias. Entonces pasamos aquí a la sala para ver, preguntar si hay alguna intervención, alguna pregunta, comentario. Sí, Germán. ¿Te puedes acercar al micrófono?
Thank you. I have 3 short questions. There are any difference between Mexicans if they are from rural or urban background? The second one is talking about your hypothesis. I know it's different if you are make these questions when they are trying to cross into the U.S. that when they are in the U.S. So you need some time in order to differentiate the application of the question. And the third one is in the 80s we were doing field work in Jalisco, and some medical staff conduct the research in Los Altos de Jalisco, and they find a lot people, women especially, with high levels of depression. And when I saw your this question from stress, I was thinking that it's more close to depression. When you are trying to measure stress, maybe you are talking about depression. So it could be some difference. It depends if you are talking in general of stress or depression. That's it. Thank you.
Thank you very much. Those are clearly very well thought out questions and that relate to the health outcome that we've ended up focusing on. Let me just tell you, I didn't pick serious psychological distress out of the air. The Kessler scale is a well used and regarded measure of psychological distress, and so I was using what was given to us. So first, let me just start by saying thanks for these questions, and secondly, your point about there being differences between Mexicans depending on whether they have rural or urban origins. Of course. Labor market outcomes, many different outcomes, remittances. Some of the work that we've done using our data from Los Angeles show significant differences depending on where somebody came from. Let me just respond to it by something not from my work, but from somebody else's work. Jeffrey Cohen wrote a book, an anthropologist. He's now at Ohio State, and I can't remember the name of the book, a couple of years ago. A study on Oaxaca City and the surrounding communities that are more rural, indigenous Mexicans. And what he found was that the indigenous Mexicans, very provocative hypothesis to me, we talked about that before, that the indigenous are more likely to come to Los Angeles directly than to go to Oaxaca City, because they're more likely to be discriminated against in Oaxaca City than in Los Angeles, because those gringos, we don't distinguish so much between the indigenous and Spanish-speaking Mexicans in Los Angeles, perhaps, as they would in Oaxaca City. So I think there clearly are differences between rural and urban areas. This is just one brief example that I think can relate to stress or depression or psychological disorders. That comes from somebody else's work, not mine. I agree with you. There probably are large differences, and that one I just mentioned is not the only one. There can be other reasons as well. The sense of failure or success in urban areas versus rural areas, and how much weight you put on your family or friendship networks in the environment you're living in, traditional values versus less traditional, more metropolitan values. I think all these things are very important, so I agree with you. And in our work, we always control for this. In this work, we have no way of getting at that, because there are no questions about where you came from, just the country. Okay? That's why we need our studies, to complement this kind of work and to see whether our findings are true. If we put a control in, for example, whether you migrated from a rural or urban area, maybe our documented effect goes away. I don't know. But we don't have the data. We will soon, though. The second question about border crossing and more permanent residence in the United States, of course. Crossing the border, and when you do it, is can be a relatively stressful short-term experience. But I'm not so sure I could hypothesize what the effect is on the stress, because just as there are stresses related to crossing the border, it's not, maybe that's a good kind of stress, actually. Maybe I should be stressed when I'm trying to run away from the Border Patrol. If I'm not going to have the hormones pumping through my blood enough to make me succeed. Or maybe sneaking in, I should be stressed when I'm sneaking in, or there's something wrong with me. It's not short-term stress that is bad for our health. That's good for us. Keeps us alive. It's long-term chronic stress. And I think perhaps that with the significant buildup of the border, the recent crackdowns by the Department of Homeland Security on undocumented immigrants. I mean, we have people moving out of their houses in Massachusetts from our surveys, Brazilians scared to death that they're going to get deported. I'm sure it's the same for some Mexicans. I think that long-term constant stress might be more detrimental to people's health than the initial border crossing. That's just my hypothesis. It could be wrong. And then lastly, about your field work in Jalisco, first of all, I'd be very interested to see it. And other work on this topic that you know of, because I'm just learning this. This is new for me. But in our results, I don't know if you saw it, we found that males were less likely to be distressed, right? So it is consistent with what you found in your work in Jalisco. Women are significantly more likely to be distressed than males in our data. And there's a whole host of reasons why that might be the case. You know the gender role literature probably better than I do, that emanates back to the 1940s and 50s and has been significantly updated more recently. Everything from self-imposed duplicate multiple roles to societal imposed multiple roles, is taking care of the children. Material differences in terms of economic resources. The networks of men in our data for Mexicans tend to be more bridging networks, or what they call linking networks in the social capital literature. Men tend to have better social capital in that measure, at least among the Mexican data we have, and women tend to be more likely and to benefit from participation in clubs and organizations. And so they benefit more by how political scientists measure social capital, and Mexican men seem to benefit more by how sociologists measure social capital. So there are many reasons why men and women might differ, why rural to urban areas might have differential effects, and why border and permanent residents in the United States might have differential effects on stress. And they're all important domains, I think, that you've hit on, all three of them.
First of all, thank you, Enrico, for being here at Colegio and also to share with us your results, your research you are doing, and we really appreciate it. The first thing is it's good to challenge the Latino health paradox. I don't know why it seems to me that it has been an abuse of this concept, because it's started with this infant mortality paradox in the 80s. And now many people use it, the whole Latino health is better than the Anglo. It's not true. There are many documentation about it that show this. It's not. It's dependent what the difference is. And just one little question in your research in terms of the associate of the legal status and the stress and all on the health issues. Because how can we control the legal status among, in this case of the Mexican? Because the legal status also is associated to others variables. And how can we know there is other reason, other factors associated to this legal status? It's not the legal status, perhaps it's the other variables associated to this condition. Just this question.
That's a great question, and the one that is most prominently and consistently asked of this. My response is very straightforward and very concise. So perhaps you'll like it or not like it, but it's concise. Tell me whatever variables you think are more important and are correlated with legal status, and put them in the model. That's it.
Education. What?
What's that?
Education.
We have it, or we had it in our model. Income. Had it in our model. We have everything you can think of that most people think are highly correlated with legal status does not take the effect away. So, it's not that, I have to flip back to my results now, it's not that these factors, I mean, if I didn't control for that, there'd be a serious problem in our results, right? I mean, we're talking about socioeconomic status here. So, for example, we have in our data whether you're employed and what your college, whether or not you graduated from college. We're controlling for these. And these are important. They reduce the probability that somebody was seriously psychologically distressed. They're in there. We don't have income in here in this model for one reason. So we have whether you're employed and what your household income is. So we have it. If you can think of other variables that would correlate with legal status, so it's something other than legal status, I'd like to know what it is. And if we can put it in the model from our data, we'll do it. If not, we need to collect it. Because right now, controlling for every single thing that we can in the National Health Interview Survey data, education, income, employment status, the socioeconomic status variables, we still have this independent, statistically significant effect of legal status on psychological distress.
But old age.
It's in there. Can you put this back up on the board? These final results? All these variables you just mentioned are all in the model. I mean, this is the point of being trained as an economist. That this is the reason why, as a sociologist, I can say, I do this. Sociologists do this too. Quantitatively oriented sociologists do this too. You can see all the way over on the left, perhaps, or you're right. We have employment, college, marital status, sex, access to care, age squared, whether you have insurance or not. All of these are markers of socioeconomic status. I thought, and I was ready for it, I thought you were going to say, where's income? Oh. Come on, you're talking about socioeconomic status, where's income? Aha. Well, if you were a labor economist in this room right now, you would know you can't have education, employment, and other factors in your income. I mean, those are predictors of income. And here's the main point. When I put income in here, it doesn't matter very much. These other factors actually matter more at explaining variation in psychological distress, not income. And here's the reason I think why. The data, the way they collect income data in the National Health Interview Survey is terrible. It's categorical. So they lump people together, you know, less than $10,000, $10,000 to $15,000, $15,000 to $25,000. And these small gradations in labor economics, we know, can matter a lot. And so I think the reason I didn't get a good effect for the income is because the income data is terrible. But, so I did the next best thing I could. I took all the best predictors that we get out of labor economics. I've taught labor economics for years. I take the best predictors of income, education, marital status, whether you're employed, etc., education, and I have them in there. So we're still controlling for the things that you think are highly correlated with legal status. And it's a great question, and I'm surprised by these results, I have to tell you the truth. Rafael Aracon will tell you, as some others will tell you, who are familiar with one article that I put up here from Migraciones Internacionales. I'm not afraid to show you results where legal status doesn't matter. We found legal status didn't matter. Whether or not you got needed medical care, for example. You say, what? How can legal status not matter on whether or not you get needed medical care? I don't know, but it didn't. Not when I controlled for income and your job. These were more important things. So if it took it away, I'd show you it took away, and I'd say there's a myth about legal status, like I called it in that article. But here it seems to matter, so here it matters. And I think there are good reasons why.
Estamos sobre el tiempo, entonces le voy a pedir a Norma y a Rafael que hagan sus preguntas seguidas.
No, I just had two variables to suggest, but I don't know if they're present in the data that you had. One is number of people cohabiting with.
We do have it. We tried it. It wasn't important.
Not at all.
Good,
okay.
good.
And the other number of hours worked.
Good. That I don't know. I have to check. Good. Thanks.
Well, it's a comment and question is, first I defend the Latina health paradox, and I say the Latina health paradox because pretty much the research conduct about maternal child care is very rigorous in this respect, and there is a Latina health paradox at this level, and that, well, it is controlled by sex, it is controlled by age, it is controlled by medical conditions, so it's very robust in that respect. I have seen also a very robust research about Latino health paradox, and I would say Latino, that includes both women and men in addictions, and it's very, very robust. So I would say that the problem here is not necessarily the concept, but the misuse that has been about this idea to extend it to other health aspects and other groups of age and combination of sex. So after saying this, I think it's great that you are working on to see the impact of legal status on health outcomes in other age groups and differentiated by sex. However, I have a problem, and maybe I think this is more a problem of trying to see how sustainable the information is coming from your study in comparison to the other studies that you show to support the existence of this problem about legal matters, legal status matters. Of course it matters. There are three concepts that you wrote into the discussion, not your research, but the discussion. Acculturization, used by Bob Calotti and Fringe, legal residence, and there is one variable that you didn't use, and I think needs to be considered, is time of residence. I think these three variables should be tested with the same kind of population that you have. And I think you can do it.
Yeah, that we can.
In order to show that it's not only important to consider legal residence, but these three things are measuring different things, and the three of them are going to have an impact of your dependent variable. So I would suggest rather than adding other indicators, I would say if you're doing this, and I think it's great, test exactly the same that you are doing with these other, let's say, predictor variables of health outcomes, especially the one, time of residence and legal status are very different things. It probably will be different sensitivities to measure health outcomes.
Thank you. Can I respond quickly? First of all, I agree with you. There is, most of what you just said I agree with. There's just a small thing I perhaps disagree with. First, there is a Latina paradox. We agree. And I agree that extending that into males and other outcomes is problematic. So I think we agree, actually, on that point. I showed evidence of a Latina health paradox. We agree. But even that, the problem is that they take this, some research, I don't think the best research, moves on to say that that's caused by cultural differences in Latinos. Okay, so anyway, there's problems with that. I'll give you that there might be a Latina paradox, but usually people automatically are assuming that that's because of something cultural and not necessarily selectivity of migrants. But in any event, that's the first point, my response. The second one is addiction. Addiction is a tough outcome for me to lump into all these other outcomes. And I think it's a very good point. Some of my own work, some of my own articles have actually shown exactly what you said. We've shown that undocumented Latinos and Latinas are less likely to test positively for illicit drugs when arrested than everybody else. So I agree with you on that note too, that they're better off for addictions. But addiction is part behavior, not just biology. So it's not just a health outcome, is what I would say to that. So again, I don't agree that we can extend this out to other areas so easily. And lastly, you say, of course, legal status matters. Well, I don't start from that premise. I'm sorry. I have no idea if legal status matters. That's scientific to me. Not, of course, legal status matters, or of course it doesn't. I have no damn idea. And the point is to look at the data we can, the best we can, and see if it does. And so your 3 points that you made about acculturation, legal residence, and time of residence, I agree with every single one of them, and especially time of residence. In fact, that's one of our predictors. But because we have a predicted value, econometrically, we're safe in having it. If it turns out to be significant, we're safe. We can put time in the United States in there. And I'm going to do that and the hours of work. These are the two best recommendations, I think, I've heard about, like, further checking these results. And we're going to do it. So thank you.
Rafael?
Thank you. Well, as usual, very interesting and provocative presentation by Enrico. Even though I like the Latino health paradox, I really like it because when Mexicans go to the U.S., you can tell Americans that assimilation is bad to your health.
Yes. This
is something that they don't really like.
Right.
But I think that you show very consistent data to challenge this paradox. And but very interesting, I think that the major contribution is to show the differences in health outcomes between undocumented and documented migrants. But now you have the problem and you have to explain why. Because it seems that you seem to suggest, and maybe I'm wrong, but it seems that you suggest that the undocumented population is separated from the documented population. Well, probably that's the impression I got. When, as you know, and we all know that in reality, the documented and the undocumented population is the same population. What we have is mixed immigration status families. People living as U.S. citizens, legal permanent residents, naturalized citizens, and undocumented living in the same household. So how can you explain these differences when you see this reality?
It's a great question. The quick answer is, and always, Rafael, your comments are very cutting, and I like it. I mean it. And so that's the next thing we're going to look at. Why does it matter? But unfortunately, the NHIS data and most data don't give you data, health data. Only have one person in the household. So you can get total number of people in the household, but you can't get the migration status of everybody in the household. That's the problem. But with our new data, we're going to be able to do that. And hopefully with the Mexican data we collect the next time, we'll do that as well. I agree with you. I certainly don't think these are separate populations. I think it's important, don't confuse analytical separations with real separations. I'm trying to get at something analytically that is very important to people in my country about the perceptions of immigrants, which I think is problematic. And so I certainly don't think that they're just living off by themselves somewhere and separate at all. I agree with you. But you're right. The problem that I have now, or I don't think it's a problem, I think it's a challenge and a great opportunity, is to try to explain why unauthorized are worse off on 2 outcomes and better off than legals on 6. That's the thing that has to be explained. So help me.
Bien, pues muchas gracias Enrico.
Thank you very much.
Gracias a Mira nuevamente y gracias a todos los que nos acompañaron el día de hoy, tanto los que están en las salas remotas, ya los que quedaron nada más en Casa Colef, y los que nos acompañan aquí en la sala del colegio. Y la próxima sesión del seminario, la última del año, está prevista para el viernes 30 de noviembre. Esperamos que nos acompañen. Muchas gracias.
Rodolfo, you have your thanks. Thanks.